Does having a low AMH mean that IUI is less likely to work for you? The answer is no, but let me tell you, this is one of the most common misconceptions that I hear all of the time. Patients find out that their AMH is low, they have diminished ovarian reserve, and they immediately often will assume the worst, that their chance of getting pregnant is doomed, even with treatments like intrauterine insemination. But our research says otherwise. So one of my colleagues at AMH of New York and I teamed up. Her name is Dr. Chelsea Cannon, and we analyzed 8,600 IUI cycles from the past couple of years at AMH of New York, where we work, and we grouped patients based on their AMH level, less than 1, between 1 and 5, and over 5. And when we controlled for really important variables that can impact outcome, like age, which directly influences the quality of the eggs being ovulated, BMI, endometrial thickness, and the type of medication that was used to induce ovulation, Clomid or letrozole, as well as the number of mature follicles produced, all of those differences disappeared. In other words, once you level the playing field and look at the bigger picture, AMH or ovarian reserve markers don't seem to predict whether IUI will work. And this has been mirrored in countless other studies that have proven the same thing. Now let's take a quick step back and talk about what AMH actually measures. Anti-Müllerian hormone is a blood test. It's a marker of ovarian reserve. It tells us how many eggs we have left in our stockpile that we were born with, but it doesn't tell us anything about the quality of those eggs or whether ovulation is actually happening in a given cycle. So when someone with a low AMH is still able to ovulate, they're still above that critical threshold that's necessary for their body to be able to respond, their ovaries to be able to respond to the signals from the brain, and they're able to mature and release an egg, then whether they're trying naturally on their own unassisted or with IUI, that success, that chance of success or an outcome that we're looking for, pregnancy, is more related to the quality of the eggs versus the quantity of eggs that are available. And while IUI can be the extra push that some people need, and it can be especially helpful in cases of sexual dysfunction, when partners are geographically separated or there's mild male factor, it's not exactly magic, right? It's really just a more targeted version of what's already happening with timed intercourse. We're just placing a concentrated sample of sperm directly at the top of the uterus at the right time so that the sperm doesn't have to swim as far to meet the egg or the eggs if you're using ovulation induction to potentially ovulate multiple eggs. If you're ovulating one egg or even just a couple of eggs, the fact that your AMH is low, the size of the stockpile of eggs that you have left at that snapshot in time is on the lower end. That doesn't make the egg any less capable of being fertilized or turning into a healthy embryo. So why do so many people hear low AMH and get pushed towards IVF right away? Well, because time equals the number of eggs that you have, and time does matter. And often doctors and clinics will see this low AMH and they might panic or feel nervous. They worry that IUI traditionally takes many cycles to be successful in most cases. And so by the time you've gone through those multiple cycles, your ovarian reserve might be even lower. And if IVF ends up being something you need to resort to later, there could be fewer eggs to work with, and that might dictate that you have a lower response and a lower overall chance of success with IVF. And this concern isn't completely unfounded. We know IVF has a tendency to be more efficient and shorten your time to pregnancy when it works well. It's especially important if you need to be as efficient as possible and you're trying to keep in mind future family building goals and wanting to preserve your fertility alongside treatment. But the fact of the matter is that if you have diminished ovarian reserve, you might not respond as well or get as many eggs at retrieval, and that can really impact the success. But young patients, especially in their 20s and early 30s, even if they have only a handful of eggs retrieved, they can still be very successful because their conversion rate tends to be very high because of good egg quality. And even in older patients, if you have luck on your side, despite having a small number of eggs retrieved, sometimes you can still make a normal embryo. Having said all that, choosing between IUI or IVF as your first step is not exactly black or white. You have to consider your age and what that means about your presumed egg quality, how many kids you want, whether you have good insurance coverage for either option, what are the costs out of pocket, how emotionally or logistically ready are you to pursue a more aggressive path. I think for someone with DOR who's focused on just getting to baby number 1, IUI can be a reasonable first step. It's very practical, even with low AMH. Especially if IVF could be limited by cost or you're only expected to get 1 or 2 eggs per retrieval anyway, IUI may give you a chance to get pregnant without going through that intense treatment and the expense of IVF. But if you're hoping for more than 1 child and you're older, or you really want to lower your risk of miscarriage if possible through genetic testing of embryos, then IVF may make more sense for you. Again, AMH will not predict whether you're capable of making genetically normal balanced embryos, but it can help estimate how many shots we'll get in a single IVF cycle. AMH can be a helpful test, but it's definitely not the whole picture. It doesn't predict your ability to conceive without our help, unassisted, and definitely does not determine whether IUI will be successful. It can help to guide strategy, but the strategy needs to be individualized and not reactive. If you're someone who's been told you shouldn't do IUI because your AMH is low, take a deep breath and realize that this is not a dead end, it's just a data point. And if you have enough eggs to be able to respond to the signals from your brain and ovulate, then you're still in the game. But make sure you're talking to your doctor about your full picture, your goals, and all of your options, because your fertility journey deserves more than just a knee-jerk reaction to a single lab result.